All right, everyone, if you could go ahead and take your seats. We're going to go ahead and get started with the next session. I hope everyone had a good break. Wait a minute. Can you hear me? No. I'm going to see if he can fix it. Because you're going to need it for the presenters, right? Yeah, okay. So we need it. Are the mics on? Okay, the mics are on. Okay. Hope everyone had a good break. Welcome back. We're going to continue our trek across the spectrum of prevention. And now we're going to talk about community communication. And individual communication. I'm sorry, I got them reversed. Individual communication. Thank you, Dr. Mitchell. And I think in the prior session, you heard about policy. And one of the keys was also about communication and sort of, I think, thinking about sort of how we can shift in terms of education and communication, both in the individual and at the community level. So in many ways, I think what you're going to hear today will sort of help to reinforce some of that policy work that needs to happen in terms of sort of mobilizing folks. So with that, it's my pleasure to introduce to you all the chair of the session, Dr. Uchechi Mitchell.
Good morning, everybody, or close to afternoon. So just want to start by saying thank you to the summit organizers for giving me an opportunity to be a part of such an amazing and wonderful and very important event. I've really learned a lot over the past day and a half, and I look forward to learning even more in the second half of the day. And thank you to all the speakers for taking the time to share your expertise with us over these past 2 days, and particularly thank you to my panelists who are here today. So this session focuses on ways in which public health can support and empower individuals to engage in healthy behaviors and make healthy choices for their own healthy goals. Hopefully in the realm of addressing dementia risk factors that we've discussed today. Our mix of presentations will specifically highlight 2 themes. The first thing focuses on health inequities and dementia risk and different ways of addressing dementia risk factors in minoritized populations that shoulder a disproportionate burden of dementia and its risk factors. And the second theme really focuses on preventative strategies and resources that are applicable for multiple dementia risk factors and work to enhance an individual's knowledge, skills, and capacity to address dementia risk factors through interpersonal supports in particular. First, Dr. Lauren Hale from Stony Brook University will start us off. She's a professor of family, population, and preventative medicine at the Renaissance School of Medicine. She will discuss sleep health, which has come up in a lot of our sessions, and the social pattern of sleep health and factors that contribute to poor sleep generally and racial inequities in sleep health particularly. She'll be followed by Dr. Susie Aguinagas, who is an assistant professor in the Department of Kinesiology and Community Health at the University of Illinois, Urbana-Champaign, who will discuss the importance of culturally appropriate diet and exercise physical activity guidelines programs that address the health needs of Black and Latino communities. Then Mrs. Constantina Mizes, the founder of the Latino Alzheimer's and Memory Disorders Alliance, LAMDA, will share with us the work they have been doing with community health workers or promotores and how important they are for a multifaceted approach to dementia risk prevention. Last but not least, Dr. Shannon Jarrett, a professor of social work at The Ohio State University, will close out the panel by highlighting, I just know you have to say the We'll close out the panel by highlighting the numerous ways in which intergenerational programming is not only beneficial for addressing traditional dementia risk factors like physical activity, but also support cognitive engagement and support other factors related to healthy aging. So thank you all for your time and expertise, and everyone, please join me in welcoming our panelists to the stage.
Good morning, everyone. Okay, I love it. Let's see. Do I have to do anything to get my slides up? It works. Okay. Here we go. So thank you, Dr. Mitchell, for the lovely introduction. It's really a pleasure to be here to talk about strengthening individual knowledge and skills around sleep health. Some of us have already been talking about sleep, and we already know how important sleep health is for brain health, but what can we actually do about it? By way of introduction, it was already mentioned, I'm on the faculty at Stony Brook School of Medicine. I also have a few voluntary extracurricular activities, all related to the idea of spreading knowledge and communicating information to translate into policy and change to help improve sleep health. These affiliations, just to give them credit, and they're all unpaid, are the National Sleep Foundation. I'm the immediate past chair of the National Sleep Foundation. You can check them out online. I'm also on the scientific advisory boards of the Children and Screens Institute. I know that seems not related to this conversation, but it is, because we all bring those screens with us to bed. And I'm on the scientific advisory board of the Pajama Program, which provides books and pajamas to low-income kids to help them get a good night's sleep. And that's a really amazing organization. And then finally, kind of the extracurricular I committed the most to during the pandemic was I was a founding member of the team of nerdy girls that created Dear Pandemic, a social media platform providing COVID-related information to the public. We have hundreds of thousands of followers and have received a lot of recognition for our grassroots work in getting our messages out there. My work was mostly about sleep health and other well-being, but of course, a lot about COVID as well. So with that said, let's dive in to the main message. If you must fall asleep after this slide, that's okay. Just stay awake for this one. This is the only one I want you to learn because this is the main message I give everywhere. And that is that sleep health is a social justice issue. Just keep that in mind. Sleep health is a social justice issue, and it is due to three truths. The first is that poor sleep health is common. I will talk about that in an upcoming slide with some epidemiological statistics. It's common and it's under-recognized. Most of you, I loved it when you mentioned sleep as one of the risk factors. It was a huge deal for the American Heart Association to add sleep as a part of the essential 8. They went from the simple 7 to the essential 8 risk factors. I love that it's also part of the conversation about brain health. The second truth is that sleep is unequally distributed. I'll be talking about that a lot today. It's really important to understand all the reasons why sleep is unequally and unfairly distributed across the population. And then the last truth, which I also want you all to take home, is that sufficient restorative sleep is fundamental to the optimal functioning of every organ in the human body. You need it for physical health, psychological well-being, cognitive functioning, and the public needs it because it's a safety issue too. So all of these things combined, sleep is a social justice issue. Now you can go to sleep, that's fine. I've only got 10 slides, so hopefully you hang in there. Some very broad statistics about how bad is the state of affairs with regard to sleep health. It's pretty bad. I mean, 30 to 40% of adults are not getting the sleep they need. The recommendation, based on 2 consensus panels, National Sleep Foundation and the Sleep Research Society, say adults should be getting 7 to 9 hours of sleep. Older adults, maybe 7 to 8. There's some controversy about if there's, a thing is too much sleep, but you should aim for around 7 to 8 hours of sleep. Sleep apnea, a treatable condition, common in is prevalent in 5 to 10% of the population, commonly underdiagnosed, undertreated and under-adhered to when proper treatment is given. And there's racial and ethnic differentials as well. So this is a treatable condition. Acute insomnia, depending on the definition, occurs in between 10 and 30% of adults annually. Again, it's harder to treat insomnia, especially if you have a hard line against pharmaceutical interventions, but there are treatments for it, and there are certainly behavior changes. And then finally, I love the people who have referenced how brain health is a lifelong activity. Our teens are probably the most vulnerable to not getting the sleep they need. Up to 70% of teens are not getting the recommended 8 to 10 hours of sleep per night. I could give, a much longer talk on this, but just know that this starts young, and disparities in sleep start young too, racial and ethnic disparities in sleep. So that's where we are in the epidemiology. Unfortunately, despite increased awareness and excitement and enthusiasm over sleep health over the last few decades, there have been continued self-reported declines in sleep health, also during the pandemic. Didn't help some groups, did help some other groups, but we also saw bigger drops among Black and Mexican Hispanics compared to whites and other populations. So we're seeing declines in sleep despite our efforts in addressing disparities in sleep. So that's frustrating for me because I've been doing this for almost 20 years. I'm like, why is this not working? And to the question of the patterning, sleep varies by so many different factors. And the bottom row are things, kind of details, but I want you to get three big themes. The big kind of social and structural predictors of sleep include education and socioeconomic status. For the most part, more status, more SES is associated with better sleep health. There are some exceptions. Neighborhood context. In order to sleep well, you need to sleep in a safe, cool, dark, and quiet environment. And not all neighborhoods can offer that to everyone. And finally, there are widespread and widely observed disparities in sleep by race, starting in the preschool years, and they extend through adulthood. Among adults, Black adults are about twice as likely to get insufficient sleep. Some actigraphic studies show up to an hour less sleep per night, every single night, than their white counterparts. These are big differences, and I believe they're modifiable. So I don't have time to get into all of these other factors, but we know there are other ways that social and contextual factors matter for sleep, including marriage, lifestyle, employment factors, mental health, and of course, screens. And I'm guilty of that too. And then finally, without going into every single process here, just know that the consequences of poor sleep health go beyond just brain health, though there are very, very specific mechanisms for clearing out waste in the brain while you sleep. There are consequences for obesity, hypertension, diabetes, poor mental health, inflammation, and all-cause mortality. So helping sleep in one domain will have a range of other positive benefits. So I sort of laughed when I was invited to give a talk on individual knowledge and skills, because a lot of what I think about and talk about are the broad perspective. But I answered this question in this one slide for today's talk. Here are the four things that I think, the categories of things in which way we can help strengthen knowledge and skills around sleep. The fundamental one is actually quite challenging, so I put it first. In order to sleep well, you need to have some amount of autonomy. I think this is part of why teens are so bad at sleeping. You need to have control over the conditions of your sleep health, including the timing of your sleep environment. I already mentioned cool, dark, quiet, and safe. And you need to have good mental health. Those are all fundamental things that are not always so easy to empower people with, the ability to have control over their sleep health. But there are things we can do to help individuals in these other buckets. The first is increase awareness and interest. And from where I sit, there's been so much explosion of information, books, articles, documentaries, podcasts, social media campaigns. There's so much more now available about sleep health than there was 10, 20, especially 30 years ago. And in addition, I talk with physicians and psychotherapists. Everybody's interested in helping their patients sleep. That's part of the conversation, and I'm so glad to see that prevalent. The National Sleep Foundation is working to get sleep treated as a vital sign. So, we're doing things to say sleep is something that should be asked about at every single visit. How are you doing? How are you sleeping? So that's one area to strengthen knowledge and skills. Another area of growth is the opportunity for wearables and all these great technological devices to help people monitor their sleep, track their sleep, improve their sleep. There's things you can wear. I've seen people with the Oura rings on today, with the wristwatches. There are smart mattresses. There are smartphones. They have apps and all these other detection devices. There's bright light therapy that you can wear on your face while you walk around and get your kids ready for school. There's also blue blocker glasses you can use at night to prevent the effects, the alerting effects of light on your eyes at night. And so there are lots of opportunities for these types of interventions. They may just make a marginal effect, but they're getting people engaged with the process of controlling their sleep health. And kind of fundamentally, all of those first three buckets can go together to help individuals have the power to act and prioritize their sleep health. And a lot of these are going to be suggestions you've heard before, but they do make a difference. And that includes having or prioritizing your sleep health, including the duration, how much time you give yourself in bed, your regularity. You want the same times for falling asleep and waking up on the weekdays as on the weekend. That regularity thing has become more and more important with recent research. That morning light, it's so essential to reset your circadian clock by getting outside. If you can, get exercise too. Get that morning light, reduce the light at bedtime, have regular calming bedtime routines. Of course, limit your caffeine and your other substances. And then probably the hardest of all, at least for me, put down your phones. And encourage your kids and your friends and all those people to put down your phones in the hour before bed. I could, again, give another hour lecture on why screens are so bad for your sleep. But one of the most interesting facts I've learned recently is there's evidence that when you're on your screens, you lose track of time. And if you're losing track of time, that's cutting into your sleep. So just remember that, put it down, and then see how you feel. And so that's my homework for you all. If you want to email me in a week and let me know how it went, just give yourself a goal of half an hour sooner. Put your phone down, charge it in another room, make everyone in your family do the same thing. See how it feels. And I love getting feedback. And if it works for you, I love that. Okay, so I'm sure I'm running way long on time, but that's how I go. Here's some recent results from the Sleep in America poll. We do a poll every year. These are some findings, just kind of state of affairs. How are we doing on health behaviors related to sleep? About half of Americans are not getting the bright light in the morning or afternoon they should be getting. Who knows how accurate these numbers are, but this is allegedly nationally representative. About a third of Americans, probably at least, fall short of recommendations for exercise. There's been more and more work on circadian rhythms and the timing of when you eat and regularity of meals. About 4 in 10 adults are not reporting eating at consistent times. And that is related to, of course, weight, but also sleep health. And there are disparities in that finding as well. And then finally, screen use at night. I, again, think this is an underestimate. About half of Americans report looking at screens within an hour before bedtime. I would love that to be the truth. I think it's much more, sadly. At least it is with teenagers. How am I doing on time? I'm going long. Okay. So here's my final 2 slides. I know this is a panel about individual health, individual behaviors. And often people do think about sleep as an individual behavior. It's like something you do alone in the dark of the night. It is like the most, it's like biologically driven. You don't even have to move to sleep. This is an individual behavior. But I want you to look at this picture, not just like glance at it, but say, look, and like, is this what you look like when you wake up? Because this is not what I look like. First of all, she's smiling, and she looks like she has makeup on. She's in a perfectly white sheets, and there's no distractions around her. When I wake up, there's an 8-year-old by my head. There is like a pile of unfolded laundry, a computer full of unanswered emails, and a laundry list of other things I need to do going on in my head. That's how I wake up, and that is the reminder that even though sleep is an individual, perceived as an individual behavior, it absolutely takes place in the context of what's going on in your household. Is there violence in your household? Is there poverty in your household? Is there insecurity? What's happening in your community? Are there politics or policies that make you feel unsafe or unhappy? What are the rules around school start time, daylight saving time? Those are the policies, that big ones that affect sleep health. And also, where, how does the structures of racism affect you on a daily basis? All of those things matter. And so keep that in mind. Even though we like to think about sleep being totally individual, it's absolutely not. And we need to work together. This meeting's just been amazing, pointing out how important the collaboration is. And, this onion figure of socio-ecological model reminding us that all of these things fit together, and we can hopefully work to make a difference. So I'll stop for now.
Thank you so much, Dr. Hale. As someone who has a toddler and an infant on the way, sleep health is hard to find right now. But this is a key reminder to kind of make that a priority. So next we have Dr. Igmanadas, who's going to talk about physical activity and diet quality.
All right, good morning, buenos dias. I first want to start by thanking Dr. Uchechi Mitchell for organizing this panel and inviting me to be part of it. So let's dive right in. So yesterday, Dr. Carrillo gave us an overview of the modifiable risk factors. And today I'll be focusing on physical activity and diet. And I'll be particularly focusing on physical activity and diet because it's also associated with several other modifiable factors on the screen, like hypertension, depression, and diabetes. So we are all well aware of the many benefits of physical activity, including a protective effect against cognitive decline. However, only 28% of men and 20.4% of women meet physical activity guidelines. And meeting guidelines also decreases with age, such that 13% of adults 65 years and older are meeting the guidelines of engaging in 30 minutes of physical activity per day, 5 days per week. And of course, we also know that there are physical activity disparities by race and ethnicity, such that marginalized populations are less likely to meet the physical activity guidelines in comparison to non-Latino whites. Slightly switching gears and talking about diet quality, we know that following an overall healthy diet is a recognized strategy to prevent cardiometabolic risk. And dietary factors like reduced intake of saturated and trans fats, increased vegetable and fruit consumption, and dietary intake of vitamins E and B12 are all associated with a reduced risk of cognitive decline and Alzheimer's disease. However, bad news, diet quality among U.S. adults is low. Only 1 in 10 adults get enough fruits or vegetables per day. And the recommendations state that we should be consuming 1.5 to 2 cups of fruit per day and 2 to 3 cups of vegetables per day. So make sure you eat your fruit cup today with your box lunch. And we also know that there are diet quality disparities also by race and ethnicity. And for example, we see that non-Latino Asians actually have a higher diet quality in comparison to non-Latino whites and non-Latino blacks. So the question here is, how do we strengthen individual knowledge and skills to improve physical activity and diet quality? And how do we do this in minoritized populations? So we can start by reframing the physical activity guidelines, which recommends 150 minutes of moderate to vigorous physical activity per week, not per day, as the screen says. Although if you can do that, that's great. However, due to several factors that we've heard all about, like the social determinants of health, or even some chronic diseases, individuals may not be able to engage in 30 minutes of physical activity per day. However, data show that it's not necessary to do these large amounts of activity due to it's not necessary to do these large amounts of activity to reduce the risk of all-cause mortality. And benefits actually start to accumulate with any amount of moderate to vigorous physical activity. So some physical activity is better than none. Now, one strategy that we can use to engage individuals in physical activity is by using the stepwise approach. So we often promote physical activity by using the elevator approach, meaning that we tell individuals who are low active and often in the sedentary, who are engaging in high levels of sedentary behavior, to go from that stage all the way to meeting the guidelines of 150 minutes of moderate to vigorous physical activity per week. But this is often really challenging. So with the stepwise approach, we can instead recommend individuals to start breaking up their sedentary time. They can increase their sit to stand transitions. They can slowly increase more light intensity physical activity. And the newer physical activity guidelines also state that there are benefits for engaging in light intensity physical activity. And then we can start recommending moderate to vigorous intensity on most days of the week. Now, when using the stepwise approach, it's important for individuals to increase physical activity levels in all of their contexts. So we want to make sure that we're promoting physical activity at their occupations, at their workplace. So individuals may already be engaging in high levels of occupational physical activity, and that should be celebrated. Likewise, we should also be promoting more household physical activity. And so older adults who engage in more household physical activity are also more likely to maintain their independence. And also, I get 7,000 steps by cleaning my house all the time. And then also we want to make sure that we're promoting transportation physical activity, meaning walking or cycling to school or work or other destinations. Of course, we need to make sure that we're using environmental approaches to facilitate active transport in the community as well. And of course, we want to promote physical activity in our leisure time. However, when we promote physical activity in our leisure time, we often opt for promoting our traditional activities like strength training or going to the gym. And oftentimes, these types of activities are not appealing for minoritized populations. So we need to promote culturally relevant physical activities, and this is critical for increasing physical activity because these may be activities that they are already familiar with. Some physical activities have deeper meanings and can connect individuals to their cultural roots, and they may also be more enjoyable. Now, some other components that are important to incorporate when culturally tailoring physical activities may be to promote group-based physical activities, and this is to foster social support. We may also use linguistic strategies where we can offer physical activity programming in the preferred language. And we can also employ community health workers to deliver physical activity programming. And then we can also leverage technology and we can offer exercise programs via Zoom or free apps. And lastly, we can also leverage faith places. So yesterday we heard all about how faith-based organizations are trusted institutions. And so maybe they could even potentially open up their spaces for physical activity. Now, I want to briefly give an example of how I've done this through my own work. And so I work with Spanish-speaking older Latinos. And so we created a Spanish language Latin dance program where individuals learn how to dance merengue, bachata, cha-cha-cha, salsa, and most recently we've added cumbia and even flamenco. And so Latin dance makes sense for Spanish-speaking older Latinos and for all Latinos, really, because it's a culturally relevant type of physical activity. It is part of our history. It is part of our socialization. Some even say it's in our blood. But beyond that, physical Latin dance is also a type of cognitive activity. So if you think about dancing, you might be learning a new dance style. You might be learning new steps. And in future classes, you may need to recall previous steps learned to form new dance sequences. It's also a type of social activity as well. So our programs are group-based and have taken place in person and through Zoom. And so again, this also fosters social support. And lastly, this is a type of an aerobic physical activity that targets the larger muscles, and it also helps improve physical function. Switching gears to diet again, there is emerging evidence on the benefits of dietary patterns, such as the Mediterranean and the Mayan diets, that help reduce our risk for cognitive decline. However, individuals often receive broad guidelines and are often discouraged to consume their cultural foods and replace them with unfamiliar dishes. Although feasible for some, access and affordability and simply not knowing how to cook these types of dishes can pose as barriers. This is where cultural tailoring of these diets play a critical role, and this is also where individuals can promote the consumption of their cultural foods. So for example, individuals may be instructed to increase their fish consumption, so they may be presented with this beautiful salmon with veggies. However, if I was promoting this with my Latinx participants, I may instead choose to promote increased consumption of fish by introducing them to, by promoting tuna tostadas, which contains canned tuna, other veggies, fresh herbs, and maybe even a little bit of olive oil as well. So we can counsel individuals about these lifestyle modifications that they can make, meanwhile promoting traditional foods and dishes that they're familiar with and are also affordable. It's also important to identify family dynamics and learn who is doing the food purchasing. Is it the same person that is preparing the food? And determining if either of those individuals receive counseling about lifestyle modifications. And if not, making sure the information is reaching those individuals. It's also important to connect individuals with local community resources to ensure that they'll be able to purchase what we're recommending, and also learn about how they store the certain foods and how to cook them as well. And so I want to give another example of how I've incorporated this through my own work. So we developed a culturally tailored Mayan diet curriculum. And the Mayan diet is the combination of the Mediterranean and the DASH diet with the most compelling evidence regarding the relationship between diet and dementia. So what we did was we offered all content and materials in Spanish. We also provided olive oil and nuts to offset any potential financial barriers to purchasing these items. We also created, we also included recipes that included typical Mexican dishes, as all of our participants were of Mexican descent, and these dishes were slightly modified to meet Mayan diet requirements. We also created these reminder aids that kind of look like loteria cards. And loteria is like Mexican bingo. It looks like this. And so we ended up collaborating with an artist in Chicago to create the Mayan Diet Loteria. And so these were actually printed on refrigerator magnets and also tote bags, so that when participants would go grocery shopping, they would be reminded of the food items that we're recommending them to consume. We also had really rich group discussions that incorporated different types of social cultural values regarding Mayan diet consumption. And these not only focused on barriers, but also facilitators and social and family concerns as well. Our group discussions also highlighted the importance of taking care of their own health to better care for their families. And so this is the cultural value of familismo or familism. And so this was also important to embed within the curriculum as well. So this is our first iteration of the culturally tailored Mayan diet curriculum. And once we incorporate feedback from our participants, I know that this program is going to evolve as well. So I have a couple take-home messages. So my first take-home message is use a staircase approach when promoting physical activity, and make sure that participants are starting slow and really try to get them to strive for the 150 minutes of moderate to vigorous physical activity per week slowly. Also, we need to make sure that we're promoting physical activity throughout all of their contexts, right? At their job, at the household, transportation, physical activity, and of course, their leisure time physical activity as well, and letting them know that some physical activity is better than none. We also need to learn about which culturally relevant physical activities are important to the communities that you work with, and we need to make sure we promote those. And lastly, when promoting healthy diets, we need to promote traditional foods because they taste better anyways. Thank you.
Thank you, Dr. Aguinaldos. And I just think it's great that you shed light and brought to the forefront the importance of culture when we're thinking about preventative strategies, as well as the importance of meeting people where they're at. So making those hard jumps can decrease motivation. So meeting people where they're at and that stepwise approach seems a very kind of advantageous approach to some of the things that we're thinking about today. So next we have Mrs. Mizes, who's going to talk about promotores. Thank you.
Hello, everyone. My colleague said buenos dias, so I'm Greek Mexican. So I'm going to say buenos dias en Kalispera. I'm happy to be here, and I'm very happy to be here because we want to talk about the importance of the community and the importance of the interventions in the community so we can reach the goals that we all have. So let's start with the big recommendation that we do in the Latino Alzheimer's and Memory Disorders Alliance, and it's the community health workers. The community health workers, for those who do not know what is it, they also call promotoras de salud. So this is what we all know. More than half of non-white Americans believe significant loss of memory or cognitive abilities is a normal part of aging. This is my Hispanic side. 2, Hispanic Americans are twice as likely as white Americans to say they will not see a doctor if experiencing thinking on memory problems. And third, 1 in 5 Hispanic Americans, that means 20%, say they will feel insulted if a doctor suggests a cognitive assessment. And thank you to the Alzheimer's Association because it's in their facts. We have more. What we also know, nearly 2 in 3 caregivers, 64% across all groups, say that caregiving is stressful. I'm going to put a pause here. Who are the caregivers in the Latino community? No social workers, not nurses. They are family relatives. In other words, the caregivers in the Hispanic community are, let me take a breath, mother, father, wife, husband, nephew, niece, comadre, friend, amiga, neighbor. Those are the caregivers that we have. As a result, Latinos are more likely to delay treatment and receive inadequate care for ADRD, exaggerated by difficult communicating with providers. So here we are. I spent the most beautiful years of my life, the last 30 years, living in the coldest city in the world, Chicago. I don't know why I didn't move from there in 30 years. But I find Chicago my home because it's if I want to eat tacos, they have a beautiful Mexican neighborhood, and they have a great Greek neighborhood where I can eat really Mediterranean recommended. They recommended yesterday. They recommended red wine, so I just follow in my background and directions. Um, in Chicago, we have a very important high number of Latinos, background Mexican. The second group is Puerto Rican. And believe it or no, between Puerto Rican, Colombian, Mexican, Guatemalan, Peru, Argentina, Bolivia, etc., 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 even if we speak the same language, we think in different. Respect is different, food is different, the way of exercise, like dancing, is very different. So, in those last 30 years, I have listening in all summits like this and conference around the nation why Latino population is not participating in clinical trials. They are not participating. They are not participating. This is all what we hear for the science people when they are in this place, in the podium. So my question is, do we invite them? Do we invite Latinos to clinical trials? We assume they know because they have a brochure in their doctor office. Well, unfortunately, our Latino community is one of the ones who have the lowest factor of education. Low education. 4 years, 5 years, 6 years. Sometimes they don't go to high school. They didn't went to high school. So they cannot, they don't even know what is a clinical trial. So just keep it in mind in the point that is so important, education. Let's go back a little bit about the health, why we need the community health workers and who they are. Let me tell you. The community health workers are generally women. It could be men, but generally the 95% are women. And those women needs to live and understand the neighbors where we want to target. We want a woman or a man who knows the who has a relationship with the whole neighborhood, including churches, schools, community clinics, and their elderments. And ouch, I'm touching a very sensitive word, politics. And no, I won't say anything about Ohio. No more. But I hear that question about what about if the next administration is not interesting in what we all want or looking for? And I'm gonna sound like my father, but it's hard to forget him when he's Greek. So my father said that in the early days of democracy, of course, under the Acropolis, they meet there. This is true. They meet under the Acropolis. This is kind of a hill, and they meet there. So every year, so they can vote. It was the first days of democracy. And what happened is that the people that didn't went to the Acropolis to vote They were arrested. How wonderful, right? This is what we need to do now. Okay, so those who didn't want to go to vote because didn't believe in the new world democracy, they arrested and they bring it to that place, the hill under the Acropolis. They have them and they have them to vote. I don't have to say this, and I was thinking about if I have to say this right now or no, but I will say it. You are an adult. Yeah, everybody's adults here. So this is also true. The people who didn't like to vote, um, they call them, they find out that they have an ideology without facts. Familiar? No, no, no. So the people who didn't vote, the Greek leaders say they have an ideology without facts. So believe it or not, it's true. They invent the word idiot. It is true. Read about history. The word idiot right now is kind of offensive. But in the early times, the Greek people invented for the people that didn't want to go and vote. So they arrested and they call idiots. The thing is here that we also need to go to the community and let them know how important it is. And let them know that I don't want to know nothing about politics. Politics is so bad. They do whatever they want. We already. Wait. At the moment that you wake up in the morning and is dressed to go to the work, in the moment that you put one step out of your house is politics. If there is lights that are working or not working, politics. If there's safe, if your neighborhood is safety, politics. And if you need to take a bus and have a transportation access to the hospital and find out what's going on with your brain, is politics. Let's start from there. So what we're doing is we train community health workers to educate their neighborhoods. We train them on a curriculum about ADRD. Please don't answer that call. ADRD. And then they go to the community. So in 2018, and this is a message from Erin Long, program officer at the Administration of Community Living. Constantina, don't forget to tell them in the summit that we give you the money for. Yeah. Erin Long give us the Administration of Community Living give us $1 million in 2018 to support the program or curriculum for 60 community health workers in the suburban area of Chicago. And during 3 years, we prove evidence-based how those community health workers work. So basically, what we have here, we let the people know that there are things, and we already know this. We just have to practice. It's like, be humble. We know what is this. Now let's practice every day and practice happiness. We need to practice happiness every day. It's not done. So we know that there are 5 domains, social determinants of health, can be grouped in 5 domains. So we know that there are things that we cannot change, but we teach in the community that there are interventions, small interventions, short interventions that everybody can do. So we divided in five. So healthcare access intervention, what we can do as community health workers, as promotora de salud. And you're gonna have this a slide, so I really recommend it to read it for the interventions because are simple and have a huge impact. Invite experts of Department of Healthcare and Family Services to inform community members about where and how to apply for medical benefits. I'm gonna take you out of your office. Please, just wear a jeans and a t-shirt and visit the community. And I'm not talking about my Latino side, every single community. Because African American community, hey, we are in the same boat, same boat. Intervention in education access. Our community health workers go out into the community and conduct educational sessions with community members about keeping their brain healthy and normal and abnormal signs of aging. This is normal, this is not normal. He's forgetting things because he's old. No, we don't know that. But we usually say that when you are Latino. Or my father is talking about going back to the rancho and 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 um and do what he did when he was in his 20s. This is just because he want to go back to Mexico. No, he is more and more talking about the older memories. It's not because he wants to move. It's because that's what he has, and that we know that. Intervention in the economic stability. Well, the economy is bad. Yeah, yeah, we know that. And every generation will say the same. But what are we doing for that? So, what we need is community health workers provide bilingual financial coaching that educate and inform the caregivers to address their unique financial needs. They receive bilingual financial coaching training yearly by Unidos US. Unidos US is former National um, National Council of La Raza. Um, yes, I have 1 minute, 2 minutes. Oh, thank you. Interventions in neighborhood transportation. 39.9 of Latinos live in households with one vehicle. Low-income Latinos spend more time traveling to daily destinations because they have fewer private vehicles and use public transit and carpools more frequency. And because I just have 2 minutes, one, I know. Okay. I have too much to tell you. Okay, so going back to the administration community living in the 1 million for 3 years, that is not a lot. You divide it in 3 years and it's gone. So 60 community health workers from suburban Cook informed a total of 6,887 Hispanic individuals about better quality of life, because the other cultural sentence is, well, there's no cure. So if there's no cure, why do I have to hear whatever you have to say? Because you want a better quality of life for you and your caregiver. 710 memory screenings in Spanish, because not everybody would like to do that in Spanish. They don't even like to conduct memory screening sometimes. Um, why is this important? It's not because the memory is screening. It's because when they listening, that there will be a health fair where they gonna conduct memory screens in Spanish. Is it becomes really interesting for them, and then is the way that you catch him to educate it in other things. A total 8,834 individuals reached through traditional and social media, um, by numbers, likes, and share, blah, blah, blah. That's the area, suburban area in Chicago. And the last slide, I'm super, super proud. Now, last fall in 2022, HERSA provide us a fund for $2 million to train 165 community health workers in partnerships with the City College of Chicago. We partner with the City Colleges of Chicago. We provide our curriculum for community health workers, and also they are certifying in the health area. We pay in every single penny to 165 health promoters to get educated. We also pay them the transportation they spend to go there, and they are extremely happy to belong to this project. Hopefully, we can educate more and certify more. Thank you.
Thank you, Constantina. And I appreciate how you've elevated community health workers as an important resource for health communication and education, but also that you highlighted the need to think about the diversity within communities when we are trying to design these preventative strategies and even think about the community health workers that we recruit. So thank you for that. And then last but not least, we have Dr. Jarrett talking about intergenerational support programs.
Thanks for the invitation to be here today. After a number of years working with community partners to deliver non-pharmacological interventions for adults with dementia, it's really exciting to be invited here to share ideas about how intergenerational can help to address modifiable risk factors for dementia. I have just 2.5 objectives for today, and those include relating intergenerational responses to 3 of the top 10 modifiable ADRD risk factors and 4 that might be considered adjacent to those top 3. Though we are addressing primarily individual knowledge and skills, my examples will bleed over into other areas of the spectrum of prevention. And I'll share some resources to increase success of intergenerational programs. Hopefully you're involved with some of these programs, or you'll be inspired to share some of these opportunities when you return home. These are the 3 top 10 modifiable ADRD risk factors from our issue brief that I'll be addressing: education, physical activity, and cognitive engagement. So there should be some connections you're thinking about just from the speakers we heard earlier in this panel. Experience tells me that it is important to define what I mean by an intergenerational relationship and program. I know there are different ones out there, but the one that I work with is primarily people who are in non-adjacent or skipped generations. So we're not talking about parents and children, adult children, and older parents. Skip generation, usually 25 years of age and younger, and ages 50 and older. With regards to intergenerational programs, these are intentional, purposeful programs that support interaction between young and older people. And they can involve related and unrelated persons, though most all of my examples today will involve unrelated younger and older people. Turning first to the factor related to education, I'm going to offer a couple of examples. Experience Corps, it's the best studied intergenerational program out there. It's operating in 16 metro cities in the US. It takes local older adults who go through extensive screening, training, and make commitments of up to 20 hours per week for a 2-year period to support children who are not reading at grade level in kindergarten through 3rd grade. Children receive a mean of 45 sessions or slightly more than one per week throughout the program period. How does this impact children's education? Because remember, I'm interested in intergenerational for the health of current and future older adults. Children demonstrate gains in literacy skills. This is irrespective of their age, their gender, their ethnicity, grade, or English proficiency. Principals are seeing these children less, 50% or fewer referrals to the principals because behavior is improving. And there's a dose response so that children who have more sessions demonstrate greater gains. These findings are important because when children read proficiently by the end of 3rd grade, they are more likely to move on to the next grade with their age peers, more likely to graduate from high school on time. The impact of Experience Corps has not been matched by other national reading initiatives that don't have this intergenerational component. It is a remarkable testament to what older adult volunteers can offer to large numbers of children. I've seen and heard reference even just this morning to the Dementia Friends program, which initiated in the UK with their Alzheimer's Association. I believe this can be mapped to community education level of the prevention spectrum. It provides training to citizens to recognize someone exhibiting symptoms of dementia and to provide a supportive environment. By raising awareness, we bring education to daily life, and people may take steps to reduce modifiable risk factors and act sooner on behalf of persons indicating symptoms of ADRD. At the state meeting of the Ohio Association for Gerontology Education, I saw a presentation that involved training university clubs and students coming through courses. I know we have field supervisors who work with university students. This could be a great way to build intergenerational connections in the community. Turning to physical activity, I'm going to come back to Experience Corps again. Intergenerational programs have demonstrated impact on physical activity in a few different ways. Those Experience Corps volunteers, particularly those who self-rated their health as fair, demonstrated increased grip strength, greater stair climbing speed, and greater walking speed. Most of those volunteers, regardless of their self-rated health, described feeling greater strength and energy as a result of participation. Something really cool is that regardless of how those volunteers self-rated their health, they had high retention and satisfaction among them, which allowed them to continue to enjoy those physical activity benefits, which lasted even beyond the period of baseline assessment. Catch Healthy Habits is another program. It is coordinated by Oasis, a nonprofit education organization in concentrating on health promotion with children in grades kindergarten through 5th grade. The programming concentrates on nutrition and physical activity, and those mentors serve as models to the young people, and they're probably learning a few things to support their good health as well. In the 5 years from 2010 to 2015, Catch engaged 23,000 youth and 8,600 adults ages 50 and older in several metro areas. 65% of those youth and 81% of those adults met or exceeded CDC recommendations for moderate to vigorous physical activity. Cognitive engagement can be supported through intergenerational programs where participants are learning together, they're teaching each other, and they're engaging socially. One example comes from a friend and colleague, Ernest Gonzalez, who described novel content as an effective practice for an intergenerational program. This novel programming was a sculpture. I don't know how many of you have experience in sculpture. From the relationship side, that helped to level the playing field so that both traditional age college students and their older adult partners were learning something new. From the cognitive science side, this offered the value of learning new things, which brings advantages to brain health over engaging in those same activities over and over again. By providing models of adults who continue to learn and grow through all stages and challenges of life, these programs can promote a love of lifelong learning, thereby setting a stage for future older adults to establish healthy brain pursuits. A couple of other modifiable risk factors I'll address as my time allows. I'm going to go ahead and start with attitudes towards self-aging. How we feel about getting older. You're living this already. I see smiles on your faces. You know that this happens. How we feel about getting older is linked to our experiences of health. And it's not just because people who have good health feel better about being older. It's because our attitudes influence our experiences of health. Even offering a 7-year longevity dividend among those people who have the more positive experiences and attitudes about aging. Dr. Becca Levy, who's pictured on the right there, along with a photo of a cover of her book that came out last year, really great stories, incorporates just dozens of studies that she's done with people around the world and very accessible for scientists and non-scientists alike. She published just last month a paper in JAMA that associated positive aging attitudes with health indicators associated with lower risk of dementia, lower likelihood of developing MCI over a 12-year period, and slower memory decline among persons with MCI. Negative ideas about aging can develop early in life, and then they become internalized and applied to oneself. Levy's research addresses a lot of this. I have a doctoral advisee, Rachel Scrivano, pictured there on the left, who's looking at interventions to reduce that self-directed ageism. And so her model involves intergenerational contact, positive aging education to promote realistic and positive expectations for old age. So intergenerational programs can play a role in the future health of these young people. Purposeful and productive aging. This risk factor overlaps a good bit with other modifiable risk factors. To encourage purposeful, productive aging and to create needed supports is to reject ageist ideas about older adults' abilities and their interests. It recognizes the strength of older persons, removes barriers, and offers facilitators of productive aging, which in turn support lifelong learning, physical and cognitive engagement, and help seeking to maintain health. This is largely why I do what I do. Having seen my grandmother care every morning for my much younger brother and hearing her say that gave her a reason to get out of bed in the morning. Not everybody has that same access to purposeful and productive aging. Ernest Gonzalez and I have been working on an anti-ageist, anti-racist framework for intergenerational programs, acknowledging that many of the persons who can stand to gain the most from meaningful roles in intergenerational programs, they may also have the hardest time accessing and modifying risk factors for dementia. They can be prevented from joining these programs because of the compounded influences of ageism and racism. So we want to see those barriers removed. To illustrate, I'm currently directing an intergenerational program that provides a gas card or a bus pass to each participant every time they join the program, because some of them would otherwise be unable to attend that event and they'd be missing out on that opportunity for a meaningful intergenerational opportunity. In a new effort on my part, we're also stipending these volunteers to come and join in, knowing that it is important and may make it easier for them to participate. The Surgeon General, Vivek Murthy, has been shining a light on the related but distinct conditions of loneliness and isolation for the last several years. Just this month, he laid out a framework for increasing connection within the U.S. in a goal to address the significant negative health effects of being lonely, which include increased chances of developing dementia. This problem has existed for decades, of course, and is experienced across the life course. It can be tempting to imagine that these rates of loneliness are more common among older adults who've lost roles and social partners, but some recent data indicate that youth and young adults have the highest rates of loneliness and isolation. And intergenerational programs have been associated with feelings of social connection. Some of you may be familiar with the Cyber Seniors program, which supports reverse mentoring and concentrates on improving older adults' proficiency with technology. It's offered as a means to reduce loneliness and isolation. So, with attention to practice that promotes relationships, the use of intergenerational strategies can contribute to that national effort of improved connection across the life course. This overlaps a lot with some other factors. I'm going to start to wrap up here. I often ask students, I try not to bring this question out at parties that I go to, give me a social issue and I'll give you an intergenerational solution for it. There are very few topics where creative, innovative, resourceful groups haven't already found solutions of bringing young and old people together to respond to whatever the needs in the community are. Where older adults have developmental needs, young people often share that need, or they have a complementary need that just can't be met without connecting with caring, trusted adults. Where young people have underappreciated talents, pairing them with older adults serves to amplify every age's strength. In some cases, intergenerational programs exist because there are efficiencies. I think we had a definition earlier for shared services. This is a step. Instead of segregating groups by age and duplicating efforts, there's value added in intergenerational. And I want to recognize that it isn't always easy to bring these groups together. There are resources out there. Intergenerational programming done poorly can be like not exercising, but not stretching after you exercise, or eating salad, but I'm not going to make that comparison. Okay, lunch is coming, and it's time for me to wrap up. So know that these resources are out there. Generations United is terrific. They're at gu.org. AARP and, oh gosh, it just left me, manages the Experience Corps program. I'm a good resource. There aren't a whole lot of us out there in the world. The Gerontological Society is managing Reframing Aging. There are good people doing good work who can help you to connect young and old. And what's really exciting, and we had reference to this in the last session on policy, is that having language in policy doesn't necessarily mean it's going to be implemented or have money behind it. The Older Americans Act reauthorization in 2020 actually incorporated language about intergenerational service delivery. So our next steps really are to figure out how we can support more older adults serving organizations to bring intergenerational into the mix. It has been an honor to share my work with you. I know my grandmother would be really proud. Thank you.
Thank you, Dr. Jarrett. And we've talked about brain health being something that we have to think about over the life course. And here we have an intervention that really speaks to the life course, which is great. So now I want to open it up to questions from the audience. And while you all fight for the microphone, I can pose a question for each of our panelists. So, given that the summit is focused on identifying actionable next steps for addressing dementia risk, do each of you mind kind of telling us a little bit more about what health agencies, public health professionals, community leaders, etc., can do to support individual capacity to sleep well, engage in physical activity or healthy eating, or can facilitate the use of promotoras and community health workers or these intergenerational programs to address these risk factors that we've spoken about today? Big question, but you can handle it.
Okay, so I'm going to get started by focusing at the policy level on sleep health. And there are two very compelling evidence-based policies that we should all be focused on making sure happens. The first is later school start time. The state of California passed legislation in 2019. Florida, an unlikely bed partner with California, just did it about 2 weeks ago. High school students are not getting enough sleep because their high schools start too dang early. They're staying up too late because of their sleep physiology, and it's not their fault. They just aren't getting the sleep they need. So the earliest high school should start is 8:30 a.m., and that is the direction that California has already started. Florida's going, other states are moving there, and if you have influence in your local school districts, you should do that. Because when kids are sleeping better, adults are sleeping better, and the roads are safer, and there are all sorts of cascading effects on health. So that's the number one, and that's not just the sleep policy, but it is. Okay, and so I love that applause. It's also very hard to get change on that, just so you know. A lot of resistance, but there is so much evidence that there should be action. The second sleep policy that's very important, and unfortunately the science goes in the direction opposite of public opinion, so even harder to change, is the recent movement to shift to permanent daylight saving time. And it sounds good, permanent daylight saving time, because people think, oh, more light, social activities, all sorts of good things happen in the evening if there's more light. But as I mentioned in my talk, we need that morning light to reset our circadian clock and also to get us to bed earlier, because light at night is alerting. And some great research on looking at within a time zone. If you live on the west side of your time zone, if you live in Michigan and you're in the East Coast time zone, that means that you're basically in permanent daylight saving time all the time. And people who live on the west side of their time zone sleep about 19 minutes less per night. That is a clinically significant sleep deficiency for everybody who's living there. Okay, that is, 19 minutes less per night than people living on the east side of their time zone, and it's associated with increased risk of cancer, lower test scores, also and more car accidents. What we need to do is push, at the very minimum, push back against the efforts to make permanent daylight standard time the outcome. That's what's currently being considered, guys. That's what's on the table, and people think it's good. We need to push back against that and shift the thinking and say, yeah, we need to stop the clock change, but shift to permanent standard time. And it will take some adjustment, but it is better aligned with our circadian rhythms for sleep health and a whole host of other health outcomes. So those are my two policies. I know I went long. In addition to that, we need communication, education, all the good stuff, cultural change, but I want to focus on those two policies.
Thank you, Dr. Hale. Dr. Alvina?
So I'm also going to echo what Amy Eiler mentioned earlier regarding evidence-based policies that can lead to environmental changes. And to add to that, I also think that we need to provide community members with the tools to lead these environmental changes in their own neighborhoods. And so this could look like traffic calming devices. It could be evening sidewalks, better lighting, cleaning up a local park, and of course making sure that grocery stores are offering brain healthy foods.
Thank you.
I will really, before everything, recommend to practice what is the other group, what is their culture. because culture is the culture is not in a museum outside. No, 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 no. The culture is every day. How we feel about illness, how we feel about death, how we celebrate, how we eat, this is culture. And this is a blessing country because it's multicultural. So that means we are more rich than other countries that are not multicultural. So by recognizing our strengths and weakness, and by recognizing that whatever is rule for us maybe is not a rule for the other group, that's the great beginning.
Thank you.
I would refer back to sessions that we had yesterday about partnerships and coalitions and encourage people to identify what the needs and the strengths are within their communities, to make sure that stakeholders are involved, and then to take on educating those small p policy makers and enforcers and big P policy makers and enforcers to understand how multiple groups can be served by sharing programming.
Thank you so much. We have a question over here.
Hi, Sarah Locke from ARP. And I love every single panel we've had, but this might be my favorite. I was wanting to talk to Dr. Hale a little bit more about sleep. I know that you said you have some other things that you want to talk about, but one of the things that struck me during our conversation with the Global Council on Brain Health around sleep was how community-specific sleep issues are. And the fact that communities where there's a lot of crime, there are the problems of lighting and the problems of sirens and noise are hugely significant for sleep patterns, and particularly in more vulnerable communities. So I'm wondering if you can say something about that, or what we might be able to work together to do on that, and then to also simply say that, yes, starting school later is a big lift and hard. I will just give you an anecdote. I'm in Anne Arundel County, Maryland. My daughter was in high school more than 10 years ago. And we were working on it, and she was testifying in front of the school board about it. It took until now. She's a resident in medical school, living on the other side of the coast, but we're almost there. Almost there, and every story that was told made a huge difference, and it just took year after year of plugging away, but we're almost there. But let's talk about communities and sleep.
Great. Also, thank you so much to your daughter for her work. I know how hard the fight is for later school start time, and the evidence on that has been around for 30 years, and it's taken that long. Back to the theme of Dr. Eiler, policy change takes time. So the conversation about neighborhoods and sleep is very complicated because, of course, there's the ecological fallacy, there's what's happening at the context, as you said, light, sound, noise from sirens, safety, all of that is happening, and those are not good predictors of good for sleep health. And then there's also what's happening at the individual level or within the household of people who live in urban areas or areas that have been less invested in. And, there's there's a lot of confounding factors, so, financial insecurity, household insecurity, food insecurity, all of those things are going on. And one of the interesting studies I've been involved in it's called the Fresh Z's study. It's a study in Pittsburgh, 2 low-income, primarily African-American communities in Pittsburgh, where one's seen a lot of investment and one has not. Investment in green space, investment in grocery stores. And what we found is that it wasn't even so much that if you but what we did find is, yes, if you feel unsafe in your neighborhood, if there's a lot of crime, if there's decay in, observable, we had field investigators go and observe the streets. If you live in a neighborhood that's observed as, high graffiti, high crime, it's worse for sleep health, objectively measured sleep health. And the investment in communities does work. And it's objective investment in communities and also perception of how you feel about your community, social connection, as well as, do you feel your community is clean and safe? So there are things you can do. There are other reasons to invest in communities as well than just sleep. but I think that's some evidence that making an investment in communities does make a difference. And, it's an uphill battle, but it's worth doing. So because of the downstream consequences for a wide range of health outcomes.
Hi there. I have a futuristic question for our intergenerational scholar. So we know that people are living longer, not in all demographics, but can you envision having somebody 100, somebody 60, somebody 20, and somebody newborn? And would you ever have a triad instead of just a dyad of intergenerational support and assistance?
Yeah, wouldn't that be awesome? I could ask you, Marcia, what kind of intergenerational would you like? I picture myself being a baby rocker in the hospitals. And that is important. We did some interviews recently in our intergenerational project contributing to resilience in teens, some of whom are in kinship care, being raised by grandparents. And we heard from the older adults who were mentoring that they thought there was a real value for the teens in having that contact with somebody who wasn't a family member, somebody who wasn't responsible for them or evaluating them. And so that speaks to the value of having unrelated persons together, even if a child might be very close, in the same household with someone of a similar age. And with greater life expectancy, if we think about that non-adjacent generation, you could have your infants and your middle-aged adults and your older adults and very old adults. We hear from the older adults too. They want to learn. They want to learn from other adults. They want to learn from the young people. It doesn't stop. And so there isn't a reason for us to think that we couldn't have 3 generations within there and have room for all the other different definitions of intergenerational relationship. Thank you.
I think this will be our last question.
I'm between everyone and lunch. That's like dangerous. My name is Elizabeth Anderson Hoagland from the Kentucky Department for Public Health. I read a blog post from someone much smarter than me talking about how our dietary recommendations so often are Eurocentric. Like we talk about the Mediterranean diet and the importance of the Mediterranean diet when that is like one specific region of the world. And that we know that lots of countries have very good health outcomes until they come to the United States. So I'd like to know a little bit more about how do we communicate about culturally appropriate food and how do we talk about a good diet that doesn't focus on that like Eurocentric view of the Mediterranean diet. Thank you.
Great question. Thank you. The tough question, right? Because a lot of the literature does tend to focus on the Mediterranean and the Mayan diet, and that's really what's getting pushed. And I think there does need to be more research conducted among other dietary patterns. So I think we need to start with that. And additionally, when individuals migrate to the U.S., we do know that their dietary patterns also change, right? And so I think what we need to do is learn about their dietary patterns that from their countries of origin and continue to promote those, right? But it might not be as easy because those foods might not be available to the places that they're migrating to. So there's so many factors involved. So I think it's first like learning about the foods that they're consuming and then also brainstorming on where they could potentially purchase and find these foods. So I think there's still a ways to go, and I think we need to do more research on other types of dietary patterns that could be beneficial for more people.
Thank you. So your question is not the last question. Lunch is not here yet, so I have to stall. Does anybody else have a question? If not, I do have some prepared questions, but I want to see audience. Okay, yeah, one great question. That's going to be fantastic. Thank you so much. So the lunch period will be extended, and the next session after this will start at 1:30, just so you know. We'll just go another 5 minutes or so. So thank you all. It's really interesting to me to think about how we can consider assets. For example, who's a caregiver, who's in the family, and Ms. Mrs. You talked about it in terms of parents, grandparents, companions, all the way down. And there's so much benefit there. So, I mean, I'm thinking farther ahead for everybody who isn't or is not, will be here at the last session. We have ways that we frame things that either celebrate the strengths of communities and families or turn them into problems. We just came through a pandemic in which we heard so often one of the problems in marginalized communities, Black and Brown communities, is multi-generational households. I don't even know what the rest of my question is. It's a comment. However, when we think about it, how do we then actually bring us back around to what we really need as a society? And how we get people to value how people live and what we do in ways that are really supportive across generations. And I will say, if we can inform people of that, since I looked up idiot while you all were talking, I really appreciate understanding the origins of that word, because there's so much about just how we talk about day to day that undermines what we're trying to do sometimes. So thank you, and I look forward to any response.
Okay, so first of all, about the Mediterranean, thank you. So about the Mediterranean diet, at home we always eat it, Greek salad with enchiladas, which was really good. So when I got married 30 years ago, my husband who's Mexican, was asking for hot sauce, and he saw me that I add olive oil, and he said, "Ugh, you don't put olive oil to a Mexican sauce, pico de gallo." And last time that we were in a Mexican restaurant in Chicago, he said he tried the chips with salsa, and he said, "Oops, this needs more olive oil." This could be funny, but let me tell you, this is Tyler. How do you pronounce Tyler? Tailor it. Oh God, there's some words so hard to pronounce. Okay. So this is what we may do all the time. Just to add slow, without your husband or wife seeing, and add some Mediterranean ingredients. Okay? But the other thing is, and I want to share this experience because it shocked me last year. We were during summer in Greece, and we took a boat to go, a small boat, to go around the island of Hydra, around the island, just to go to a beautiful beach where outside of the world, right? So we were like, I would say in that boat, we were like, 25 people, maybe 30, all tourists, and the captain, of course, a Greek, etc. So the captain. So it was maybe 100 degrees, very hot. And we finally get to the beach, and we all stand up to get out of the boat. and you are thinking, because it's Greece, it's not United States, so are stones everywhere, and if you fell down, it's your fault, nobody else, and this kind of thing. So we were waiting for the captain to help us and jump outside of the boat. Common sense for us. So as soon as the boat just stopped, the captain say, "Okay, guys, bye," and he jumped to the sea because it was too hot for him. He just jumped to the sea, and I looked at him and I said, "What?" And he was like, "Oh, this is refreshing." What I'm saying in that moment, it was like, clink. This is not only the Mediterranean diet. What we discuss in this sea is the way that we live. It's not only the Mediterranean diet. Let's put attention more on the way that we live, the daily little things. I just want you to keep in mind how important it is. It's important. I'm eating very well. I'm eating my Mediterranean meals, but if my actions, my daily activities are not congruent with what I eat, that nothing would happen.
Thank you. Okay, I think we can get lunch. Thank you again to all the panelists. Thank you for the questions and your attention. This was fabulous. Next session again is at 1:30, so we pushed it back a little bit. Thank you.